are going to delve into the session right now. So I am going to start with, I'm going to start with Dr. Daniel. Yep. Dr. Daniel, so I'd like your take on, since you're talking about healthcare financing, I'd like to know what ways healthcare financing can be adapted or adopted or improved to better meet the needs of both patients and healthcare providers. So I'm starting with that because you can just do a small, introduction to the whole healthcare thing, and that's why I want to start with you. And then you can tell us how it can be improved upon what we have currently, how it can be adapted to better meet the needs of both patients and healthcare providers.
Yeah, thank you very much, Famonia, and thank you to the Drugstop team for having me on the call this morning. Essentially, in healthcare financing, essentially it speaks to health insurance, and it is the application of the principles of insurance, which are, risk pooling, risk sharing and resource pooling. So essentially you have people pool their resources together, and then by so doing, they're able to then, spread the risk, because different people would have, different types of risks. Take car insurance, for example. The risk of you having an accident is different from the risk of me having an accident. We then pool our resources together into one pool so that we can cross-subsidize that risk. So I can use my lower risk to sort of dilute your higher risk. So the same thing, essentially applies in healthcare financing and health insurance generally. So the principles that are being applied here are the principles of managed care, which includes cost effectiveness, meaning that as healthcare providers, in participating in the health insurance space, we must have that understanding of the baseline of the background principle, which is the principle of cost effectiveness. So when we then get into the more technical conversations, things like the use of generic first, the use of step therapy and those sort of things, we are able to understand what is driving that initiative. We're able to understand what is driving that approach, because we know that in health insurance, we're essentially looking to have cost-effective outcomes. So we're looking at the minimum or what will give the best results with the least possible input into it. How can we improve? Essentially, we have to build collaborations across the ecosystem. There is a systematic distrust between both regulators, between essentially all stakeholders. We have the regulators, we have the healthcare providers, and we have the HMOs or the administrators, those that administer those schemes. So we have to be able to get past the era of systematic distrust and move to more collaborative ways of working together, so that we can give the patients better outcomes. So let me just stop the introduction there. I will get into the nitty-gritty and further questions.
Thank you very much, Dr. Daniel. That was very, very insightful. Like what you said about systematic distrust is so spot on. That's what I was saying when I introduced it. Like everybody, we need to learn how to trust one another, basically, and people that we are partnering with. So to now really delve into the meat of the issue of collaboration. Famfolake, please, I would like you to answer this for community pharmacy practice. How can community pharmacists collaborate with other healthcare providers to reduce out-of-pocket expenses for patients? I don't know if you got that question.
Yes. Thank you.
Okay.
Thank you, thank you just for having me here.
Okay,
basically, community we've been doing such collaborations with few HMOs whereby they can come to the pharmacy. Oh,
you're clear now. Yes, we can hear you now. Yes, we can.
Now.
Yes, we can.
Okay, thank you. I said one. Okay. Pharmacists can actually work with us, the nurses. We can work to maybe pick cheaper drugs. Some doctors now, they just say, okay, they want a particular brand of drug, and that's not okay for everyone. So pharmacists can work together with healthcare providers like doctors, physicians, nurses to pick a better brand of drug for our patients. Pharmacists can also, collaborate with physicians and nurses. There are some schemes that we're trying to develop too, like hypertension management schemes, diabetes management schemes. Instead of these people having to always walk to the hospitals every time to go and, check their blood pressure, check their blood glucose level, why can't pharmacists and healthcare providers collaborate in a way that we'll be able to, have a better plan for these people? And also, if pharmacists also have better knowledge about insurance and health insurance majorly, they can give these clients better information on which one to choose, how best to help them. There could be anti-malaria plans that, okay, you could just come to the pharmacy every time you have malaria, and then you've already paid to maybe one insurer or so, and then you just come to the pharmacy and then you pick up your drug all through the year. You won't have a problem of having to spend out of pocket all the time. Do you understand? So I feel those are the points that I feel that can help. Thank you.
Thank you very much, Folake. I hear you when you talk about the prescription from doctors. It's so serious, because many times, like when I was in community practice, a patient could come with a particular brand of medication, and they would have walked half of Lagos, length and breadth of Lagos, and then we are trying to explain that, mama, speaking the much Yoruba I know, trying to explain that this medicine is not available. But then they'll be like, this is what the doctor wrote, this is what I must get. So but if probably a generic was the generic name of the medicine had been put there, it's so yes, partnering with doctors, just a general increased knowledge overboard. I think that was very spot on, Folake. Thank you. And of course, all of these other schemes you mentioned. Yeah, I mean, in our session last month in September, where we talked about universal healthcare coverage, I'm sure that some attendees that are on this call and were on that call can see like a trend when we're talking about how affordable healthcare is the first step to achieving universal healthcare coverage. All right, so thank you so much, Folake, for that response. And Dr. Hope, so let's come at it from the hospital angle. So in your years of hospital practice, how have you seen that out-of-pocket expenses impact patient care and treatment outcomes?
Yes, good morning, everyone.
Good morning.
Out-of-pocket expense is beginning to impact patient treatment and outcome so badly, especially in recent times. The inflation is not smiling at anyone at all, and every hospital has to increase their charges, and then of course it all boils down on patients that pay out of their pockets. Now, before they even come to hospital, they would have delayed, in terms of trying to find out, if I take paracetamol, it might just go up and all that. So there's delayed treatment, delayed access. And before they also come to hospital, they would have gone to one or two places, spend some more money and then come to a hospital, and when they come, even we're in the era of patient-centered care, so they are the ones that will eventually decide what they will actually take. So you give them the treatment options, the best options there are, and they are telling you, can you please skip the laboratory test? Can you please take off this drip and give me that? And at the end of the day, the outcome, sometimes you even want to admit them and they don't, there are cases for admission, and they will say, I'll be coming every day from home and all that. So at the end of the day, the treatment outcome is really usually not the best. Yes.
Thank you very much, Dr. Hope. And then what you said about self-medication, it comes in all forms. Like these days, we have people we have people that have a lot of other alternative sources of care. We have people that hawk all of these agbos, and then they're supposed to be prescribed as all in themselves. You just tell them what you want, what's wrong with you, and they don't mix it in quotes for you. So we see a lot of people actually patronizing these people. And I think the bad part of this is that we don't know exactly what is in all of these things. We don't, the doses are not standardized. So it just leads to more problems for everybody, even the healthcare providers, because it's more work, more bills, and clients and patients are not able to meet up to these expenses. So it's just an all-around messy situation for everybody. Thank you very much, Dr. Hope. Dr. Daniel, do you want to say something on this?
Yes, I do. So the truth is, it's commonly said that the health of a nation is the wealth of that nation.
Sure.
Nobody should have to think about money when they need basic healthcare. It shouldn't happen. That's the ideal situation. Unfortunately, in Nigeria, that is not our reality. Our reality is that 90% of people today still pay out of pocket when they need to seek healthcare. And in fact, there are two levels of, healthcare, of out-of-pocket healthcare expenditure rather. There is the one we call impoverishing, meaning the healthcare expenditure that an individual makes that pushes him below the poverty line. And there is the other one we call catastrophic. That's the healthcare expenditure that somebody makes that is that is 40% or above of his or her disposable income. And the trend in Nigeria today is that a lot of people make both impoverishing and catastrophic healthcare expenditure, and that should not be. So the impact really is very clear. And like you have pointed out, the result of that is that we see people then looking for alternatives. People, instead of showing up in a properly registered and a standard place where they can seek care, they would rather just, seek, just resort to self-medication and, just go to either traditional options that, like you said, are not standardized and could have a lot of, terrible adverse effects. So out-of-pocket expenditure is something we need to be very serious about, and we need to really keep out of our system. With 90%, I mean, if you go to America, we're talking over 90% of people that are covered. In Europe, in some countries, almost 100% of people, that don't have to think about money when they need to seek for care. But here, just about 10% of us, have this financial risk protection. And that means that almost the whole population have to think about money when they need to seek healthcare. And that's something that we need to be very, very intentional. And I'm happy that the conversation is not just being limited to government and regulatory spaces, but then we're extending the conversations to other stakeholders, such as healthcare providers, community pharmacies, hospitals, so that we can also see the role and part that we play into ensuring that we increase the coverage. Because like I said, it has to be a multifaceted approach, efforts being made from all stakeholders to ensure that we stomp out of-pocket healthcare expenditure or reduce it to the barest minimum.
Thank you very much, Dr. Daniel. Thank you so much for that addition. And that was just well put. And as a follow-up to that, to what you have said about how healthcare providers, how other stakeholders are becoming a part of the solution now. So what role would you say that healthcare supply chain management plays in reducing costs in the scheme of things?
Yeah, thank you for that question again. And before we even talk about healthcare supply chain management, I think first is the healthcare providers. The first thing is there must be a willingness to participate on the part of the healthcare providers. The healthcare supply chain management is essentially a subset of the healthcare providers. Sure. If I work in a hospital where the management of the hospital do not wish to participate in health insurance schemes, then there is nothing I can do. There is already a management focus that is averse to health insurance. So there must be that willingness to participate. And I think that the willingness to participate should be born out of an understanding of the benefits that the scheme gives, essentially seeking to protect individuals from the adverse effects of having to pay, out of pocket. Once there is that willingness to participate on the part of the organization, and there's a strategic, drive to actively be a part of that ecosystem, supply chain management can then come up with several initiatives, that they can use to support that goal. First is strategic sourcing. We must source strategically. We should go past the, era. Recently, I was interacting with a particular hospital, and, some of the staff of the hospital were complaining about how the people that supply them drugs are people that have been supplying them drugs since the 70s, because this hospital is a very old hospital, since the 70s, and that they already have some sort of relationship with the owners of the hospital. And regardless of whether they are competitive or not, the owners of the hospital just trust them, to give them the best, and they always use them. Unfortunately, these guys, because they have seen that market as a captive market, they have essentially ripped them off, and the rates at which they are, giving them the drugs are far above market rates. So in strategic sourcing, a key component of strategic sourcing would be competitive sourcing. So we must ensure that, there is competitive sourcing. We're looking at all the alternatives that are available in the market. Also, data-driven sourcing. How much drugs am I stocking in my pharmacy? It's very important. How much consumables am I sourcing? Am I making those purchases based on the consumption data of my organization, or is it just an anecdotal or personal, I just feel that this is how much I should buy? So data-driven sourcing is also very important. This would avoid things like stock out. So you don't hear patients say that, they don't have essential drugs, when they need them. Also, some other things we can do is we can leverage on partnerships. There are some initiatives such as what Drugstock is doing, whereby, we can have vendor-based or vendor management, VMI, that's vendor management of inventory, whereby you can outsource your entire hospital inventory to a third party who can give you, competitive rates and ensure that, you are getting the best. And as much as possible, these people also help, to prevent stockouts and help you manage expirations. So all the supply chain and vendor and inventory management strategies, such as, first expire, first out, first in, first out. We can apply all those things to ensure that, we are not having dead stock lying on our shelves. And then most importantly, as I round up this point, is value-driven sourcing. It's important for us to not only look at cost. Typically, within the supply chain space, we are always focused and hung up on costs. Cost reduction is what everybody's talking about. But it goes beyond cost reduction. Value-driven, sourcing is also important. Imagine I have a particular vendor who is ready to have me, pay in advance for a particular quantity of a particular item based on my data, based on my consumption data. And I strike a deal with them that rather than hold this thing, in my own store and increase my carrying cost, I can pay down, lock the price at current rates, and have you deliver it to me, as needed, so that, I can just trigger a requisition whenever I need it, and you can have it supplied to me. But then I've been able to lock down the price because I made the purchase, at an earlier date. So this sort of initiatives that is essentially value-driven can also help. And permit me to just chip this in. There is also the part of where there's collaboration with the regulators. Recently, the NHI started an initiative where they were producing, they struck partnership with certain pharmaceutical manufacturing companies, and they were producing some essential medications that were expensive for providers to have access to under the scheme. And they were then making those medications available to providers at a subsidized rate. So I think these sort of initiatives can go a long way, to help us get a better outcome and reduce the out-of-pocket burden that the patients eventually have to face. Thank you.
Thank you so much, Dr. Daniel. That was such a robust response to that. And I was even taking notes myself so that one, reflect on it too. It's a lot of strategy and a lot of thoughtfulness that has to go into supply and into like creating your OS list. We have to be strategic at this point. You can't just do anything on a whim anymore. You have to have data that will back up your decisions. And everything just has to be intentional. You have to be intentional. There's no, I don't think there's any other way to put it. Thank you very much, Dr. Daniel. And then speaking of data, I know that data always finds its way to creep into the webinars that we organize, because data is so crucial right now. Yes, it's so critical. I think it's like the oil of then. You have to use it. Like, and it's so interesting because it is your data, like it is your business, it is data of your business, and it wouldn't speak well at the end of the day if you have all of this at the tip of your fingers and then we're not using it. So speaking of data, Famfolake, what role would you say? So this is for you, Famfolake, from the community pharmacy aspect. What role does technology and data play in identifying opportunities to reduce out-of-pocket costs? And how can different sectors within the healthcare leverage this? So how can you, in your role as a community pharmacist, how can you leverage data and technology to identify opportunities to reduce out-of-pocket spending?
Thank you, Inye. Well, for technology, there are a lot of that. There are a lot of those now. A lot of health apps that, people just, without having to get out of their bed, they are chatting the pharmacists, they are chatting the doctors, virtual consultations, they are ordering their drugs, we are delivering the drugs. There's no having to get out of bed. Even some HMOs, they have those apps that people can just chat a doctor, and then you then go to the pharmacy and go and pick up a medication without having to leave, having to go anywhere. So that's one way I know that technology has really helped. For data, I believe insurers can use maybe predictive analysis and then majorly data to actually design some programs that will help reduce out-of-pocket costs. I think I've heard of a particular HM, I'm not very sure now, that what they just do is I think you just go and pick up anti-malaria from different pharmacies. Like you just go and pick up anti-malaria. I'm sure they would have used data. I also know of one that they're specifically for I think executives or the busy 9 to 5. So I think what they do is that they just want those particular set of people to just go to some pharmacies or some hospitals to just go and get medications. So I think data is very important now, like you said. So I believe that's one of the ways that you can use data. And for technology, like I said, health apps, virtual consultations, you don't have to get out of your bed, you don't have to even leave your house, you can do it anywhere. Thank you.
Yeah, thank you. Healthcare at your fingertips. I think that's just a perfect caption. Yeah, thank you so much. Dr. Daniel, do you have anything to add to that from your perspective?
Yeah, I do. Essentially, if we look at the value chain of healthcare, almost every plug or almost every point can be plugged with data and technology to improve it. If you start from the HMO end, of course, we have seamless enrollment. You want, your enrollees to be able to enroll quickly and have access to care. That can be done. You can leverage on data to have that done. And then you want them to be able to know, you want them to have a better customer experience. So CHMOs these days give them an app whereby there's transparency. They can know what their benefits are. And this is equally beneficial to the providers because providers can go, into that app and know what the benefits of their release are. And this essentially gives a better customer experience for the patients. They know the hospitals they are eligible to, and they can, they can get the location, the phone numbers of those hospitals. And then next is they can help to schedule appointments. Scheduling appointments also help reduce waiting time, because when I know the hospital, I can use their contact, I can call them, let them know I'm coming in, and then they can give me the best time for me to come in. So this helps to reduce waiting time, which eventually improves, the customer experience and patient satisfaction. You show up at the hospital as well, using data and technology to, real-time eligibility check, also very critical. And every provider must become tech-enabled. I think we're going past the age where, providers were averse to the use of technology. Uptake of InsurTech on the part of the providers now is perhaps about 99 or even 100%. So, providers use that technology to check eligibility and check the benefit cover. And this also reduces the time that typically we spend to reach out to the HMO to try and know what this person is covered for or not. And in the end, still trickles down to better patient experience, for the customer. And then also, like Folake said, teleconsultation. Having worked in that space for a long time, I can tell you that well within 60% of the consultations that happen can be done remotely. So, leveraging, teleconsultation to give the patient that ease of access such that they don't even need to leave where they are. They can, from the point where they are, have, consultations done. These days, you could even have laboratories come to collect their samples where they are, have the tests done and results delivered to them. And they can also have pharmacists or pharmacies, yes, deliver, their medications to them as well. I think this is very critical and it will really help us. And then also the data on the healthcare or the encounter data is also relevant for planning. We can gather it, and the challenge we have is that we have all these systems that are in silos, different HMOs, different healthcare providers having different systems, and we don't bring that data together to form what we call a big data. If we are able to harvest these data from the different stakeholders, we can now use that data to plan, to say which services are the most accessed, which services are the most needed and most critical, and we can then come up with inventions or strategies to give us better results for those particular illnesses that have been identified.
Thank you very much, Dr. Daniel. Thank you very much, Folake. Both of you have really done justice to this question, and it's seeming to me like we need to have a follow-up conversation on where we can naturally talk about the role of policymakers, because it would be nice to be having conversations such as this, and someone that has a big man that can naturally take this up is there listening to this, and we have more voice. These are very quality stuff that have been said. I really hear you when you talk about prediction, having all of those data that we can use to predict and plan for future healthcare needs, healthcare planning, like in the robust sense of it. Thank you so much, Folake and Dr. Daniel, for answering that question. And Dr. Hope, so we've talked about how, at least largely talked about how within the supply chain system, we can balance the need for quality medications with reduced out-of-pocket expenses. In hospitals, like within hospital settings, how do we balance the need for high quality care with the pressure to reduce out-of-pocket expenses on the part of patients? How does it happen there?
Truth is that it's so huge. The burden is so huge. You're torn between giving the patient the best treatment he should have or she should have, and the fact that he or she has to pay out of pocket and does not really have that money. So healthcare providers find themselves having what is called indigent fund, indigent stock, indigent, so they leverage on that. Sometimes, like in Nigerian Railway Corporation, there's a pool of fund for indigent. It's at your discretion now to know that this person can't really afford this, and so you get to treat such people there from that stock, and it's a kind of revolving fund. But for those that can afford it, you really treat them and give them what they are supposed to have. It's really a tough decision most times to make, especially when you find, okay, there are some situations that you can find that the patient requires to be transfused with blood, for instance, and the relations are running helter-skelter. Everybody comes you know, they file up to see the patients, but no one is willing to donate. You know, and even when they are willing to, they are checked, and truly, their PCVs are not up to the level to donate. And then what do? You know, so again, you have to rely on that indigent one to be able to procure blood from blood banks and transfuse such people. So it's really a tough decision most times to make.
Thank you, Dr. Hope. It's a really critical situation that you are in. And, you know, if you ask me, the indigent fund, it has to keep being funded. Yeah, so that's why it's a fund. And well, so that's why we are here talking about this. We hope that conversations like this really birth solutions and results for patients. And so we have to talk about how the role of patient education in making these things better. So how can patient education and awareness campaigns be used to empower patients to seek options that are targeted at reducing out-of-pocket payments? How can we leverage patient education to do this? So I'm going to start with Famfolake, because I know that you are directly patient-facing as a community pharmacist. How can we leverage patient education to do this?
Yeah, I believe if pharmacists get to know better about all this these options that people really do have, if we have people that can, you know, educate us, let us know all the options that people can get, I believe it's very easy for patients to get knowledge about these things from the pharmacy. Like we all know, we are their first point of call most of the time, especially those that don't even have any form of health insurance and like, but their first point of call, they just come and then they complain and then we attend to them. And sometimes if the drug is even expensive, they are complaining, they are this. So it's from that point, I cannot afford this. Okay, do you know that if you subscribe to this particular plan, you can get to come here, do this, get this for a whole year, for 6 months, for a whole month, even with your family members, even with your children, you know. Those are the ways that, so I believe that it has to start from the, okay, this health insurance, or the people that want us to educate them, let's start with that. Tell us what you want us to say. Tell us what you want us to do. Let's start with the pharmacy. And then I just believe if we can educate the pharmacist and the pharmacist assistants, patients will get to know about these things well.
Thank you, Famfolake. Thank you very much for that response. Education even starts with the healthcare providers themselves. Thank you. Dr. Daniel, do you want to add to this?
Yeah, like she said, it's very critical for patients to be educated. Essentially, the health insurance, I mean, it stands on 3 legs. You have the patients, you have the regulators or the HMOs, and then let's just generally call them the administrators, and you have the healthcare providers. And since we are in this forum that is focusing majorly on the healthcare providers, I think it's important for healthcare providers to play their part in the education, because I think that those 3 stakeholders must play a part. The administrators must play a part, and the the healthcare providers, they need to play a part. The reason why it's important for the healthcare providers to play a part is that because, like it has been pointed out, they are the ones that actually render the care. There is a higher tendency for the patients to believe them. So if my doctor tells me that this is a scheme that I should sign up for, I am more likely to believe, you know, that it is true than if, you know, a third party who I don't see, don't know, and I don't interface with. So that personal touch that the healthcare provider brings into that education mix is very, very critical. And that's why I think that healthcare providers must participate in this education of the patients. And the education should go beyond just, typically in hospitals, we have some sort of administrative structure whereby there is an HMO desk or a billing unit. Almost no education goes on there because those guys are swamped with work. They are patients, lining up, and, they are filled to their teeth. They really don't have any leeway of space or time to be educating a patient on what is covered from. Many times you see them even resorting to gimmicks that eventually, make the patients even more infuriated, like them telling patients that, your HMO is here to respond when they have not actually sent the request. But the consulting room education, and this means that the regular physician should be able to identify and know what exactly the benefits of these schemes are, so that they can then, from that position, in the relaxed atmosphere of the consulting room, engage the patients, or within a community pharmacy, engage the patients to make them know why these schemes are beneficial for them. And that means that the regulators must in turn seek strategies to educate the healthcare providers as well, because the healthcare providers would be in the best position, to convince these patients, to increase the uptake of this scheme. So that's where and how I think that, healthcare providers, can play a key role, very key and pivotal role in the education of patients to have the scheme. Also, the truth is patients can also educate. And the way patients can educate is through referrals. And referrals will only come when they have excellent care. So if healthcare providers treat patients right, don't discriminate against them because they are insured patients, and try as much as possible to give them best, to make them satisfied, those patients will in turn go back, to refer others to the scheme, and they will then become ambassadors of those schemes. I once worked in a hospital where the internally generated revenue of the hospital grew by well over 1,000% because we had a visionary MD who believed in health insurance scheme, and at the time was moving, what's it called? The healthcare providers were empowered to enroll people as well. And we went massively on massive enrollment, and internally generated revenue grew, the hospital started to expand. So those are the sort of roles that we can play, encouraging enrollment, which would eventually trickle down into more revenue for us.
Thank you very much, Dr. Daniel. Dr. Hope, Dr. Daniel, through you on your own, and they came to meet consulting in the consulting room. So in the consulting room, how does this happen? Patients education.
Oh, he has said it all. Dr. Daniel said it all. It really works. And I can tell you of one that actually worked. There's this scheme. It's called the GIF Group Individual Family, GIF, GIF, SHIP, then a social health insurance scheme. Now, a group of people, not less than 3, come together under one name and register with the National Health Insurance Agencies. And I think each person gets to pay 15,000 naira a year, and you choose the hospital where that will be your healthcare provider, and off you go. You can access care. So once you tell people about this, and they gather their family members, and they're so happy about it. Like the downside is that somebody that used to come to hospital once in a month or once in 2 months begins to come to hospital 5 times in a month, because they now know
people want good health.
But all the same,
That's it.
but all the same, it's a patient education. It works, and not just the doctors themselves. It starts from the records department down to the pharmacy, to the consulting room with the doctors, the nurses, and all through the patient journey in the hospital. They are educated.
Thank you so much, Dr. Hope. Thank you very much. So I'm going to I have another question. Well, we are rounding up the session, but before then, there is a question in the Q&A session. I'm going to break protocol to take this one because I think it relates to something that Dr. Daniel said earlier, and I don't want us to go too far. And it says, can we therefore identify the healthcare providers ecosystem? And then another one is from the same person, Dr. Daniel, am I to believe that the NHIS branded drug program is up and running, or is it still at the concept stage? Yes. So those are the questions for Dr. Daniel. We can quickly take that before we go.
Okay, thank you, Moses, for your question. I mean, the healthcare provider ecosystem essentially refers to the players in that space. That would include hospitals, diagnostic centers, community pharmacy, essentially those that provide healthcare. So those are the people that would fall within that space. So diagnostic centers, laboratories, and of course, community pharmacies all play a key role in that ecosystem. And then if we then take a broader view at it, of course, we would have to expand it to include regulators. So regulators, for example, if you're in Lagos State, such as a farmer, they are within that ecosystem. NHIA are within that ecosystem. And then we even have those that support the ecosystem, such as the pharmaceutical companies, companies like Drugstock, companies that medical equipment, that essentially ensures that the healthcare providers are able to do, the work they do. So everybody will fall within the ecosystem, and these are relevant stakeholders that we really should be identifying when we are thinking about strategies to implement, because eventually they would have a role to play one way or the other into optimizing the output of the ecosystem. Unfortunately, I am unable to confirm whether the branded drugs of the NHIA program is live. My organization recently just got our accreditation. I know that an MOU was signed sometimes in October last year with about 20 or 12 or 13 pharmaceutical manufacturing companies for about 33 branded drugs. But I am not sure, I'm unable to confirm if that program is live. When I saw the question, I tried to reach out to a friend in regulation. He's not responded yet to confirm if they have actually started giving, that medication. If I get a response before the end of this meeting, I will let us know. But in my center, we are yet to start having, like I said, we have only just recently enrolled on the scheme. So, we're not yet seeing the patient, but in some of the places I've worked before, of course, we've done that, but I cannot confirm if they have started, or if providers have started receiving those medications from them. All I know is that there was an MOU signed, and we hope that, it eventually results into drugs on the shelf in our hospitals, cheaper drugs on the shelf. Yeah.
All right, thank you so much, Dr. Daniel. All right, Moses, we have answered the first two questions. I can see that there's a third one, but before I take your third question, let me ask the panelists this one. So given the current healthcare landscape in Nigeria, I'm not going to go into it, so we know what the landscape is. Where do you see the most immediate opportunities for reducing healthcare costs while maintaining quality of care, or improving quality of care? Let's use the word improving. So where do we see the most immediate opportunities for reducing healthcare costs, given the current healthcare landscape? So Dr. Daniel, still right on that. Well, let's hear from you.
Yeah, so where do we see the role of policy, right?
So where do we see the most immediate opportunities for reducing healthcare costs?
All right, yeah, so I think based off the back of previous conversations we've had, first is that, there was a major shift in that industry sometime in 2022 when the then president signed, the NHIA Act, essentially making health insurance mandatory. And of course, there's been a bit of a drag in the implementation of that, because the policy guideline only just came out sometimes, I think, October or September last year. And because of the policy is taking its time to eventually have, a foothold. As you would expect, sometimes these things take time before we eventually see it being, effectual or applied in an effective way. But I think that the place that, in view of that law that was signed, I believe that we should eventually see better uptake, right, of health insurance. there is still, of course, the change of government is also one of the critical things that has led to, the drag in the implementation of that new act. But hopefully, if we can get it right from the political will point of view, we should have more, we should have more people, switch from out of pocket to, being financially protected, meaning that as healthcare providers, we should start looking to play within that space at an optimal level. Now, what do I mean? There are structures, administrative structures, that people that participate in these schemes need to put in place. I alluded to, having a billing office and being able to manage the authorization processes and being able to manage the, the administrative side of the work. It's also important. Hospitals that have a robust team around that usually have a better patient experience, because their patients are not having to wait because they need approvals, or not having to wait for aeons just for approvals and for them to access the care that they are already eligible to. Also, we need to look at what the benefit cover is. If, as a healthcare provider, I want to roll out services, I must see the services that are covered under the scheme and tailor my own offerings towards them. So, and like I usually say, it's very important for healthcare providers to determine how exactly they want to play. Do I want to play within that space or not? If I want to play within that space, then the services I'm offering should be things that are, data driven based on what the scheme covers. If the data, in the scheme is that 60% of things that are treated are, primary care related, or probably even 70%, then that's what I should tailor my services to. If the scheme says that 60 or 40% is malaria and sepsis, then it should also drive the way I stock my pharmacy. It should also drive the personnel, that I make available if I want to be a profitable player, within that space. So that is how I think that we can leverage from it. And those are the opportunities that exist. We can look at the fact that there is a new law, it's been signed, and hopefully it should take up anytime soon. We should see increased coverages. As at the time when the law was being signed, Lagos State was probably at about 500,000 coverage, but recently they celebrated 1 million, residents of Lagos that are covered. So as more people come into that space, there will obviously be this space will be more capitalized. And once the space is more capitalized, opportunities, that exist. So my offerings and giving to play within that space, if I want to play within that space, and this affects, my supply chain management and my human resource management. So that is how I think providers can strategically plan so that they can take advantages of the changes that are happening within the health insurance space. Famoye?
Okay, can we hear me?
Yes, we can hear you now. Famoye, are you still there? Okay, perhaps while we're trying to get her back, maybe I can speak to the third question that Moses put in the chat box. So yes, Moses, I see your comment and you are right? There is a structure to the administration of the schemes, right? And there is a structure to the administration of healthcare generally. However, we need to understand that not everywhere is urbanized and not everywhere is, structured as Lagos State or structured as, the metropolis that we have around. And this is not something, and you can do your research, to check. This is not something that is limited to just Nigeria. There are places where we have had to leverage on, community, community healthcare workers, let me put it that way, or people that are within the community. If, for example, you go to a local government, say up north, where you don't have as much, you don't have hospitals, so there is a paucity of hospitals in those places, and the paucity of healthcare workers, of course, which eventually causes the paucity of hospitals, because if you build hospitals and there are nobody to work there, or there's nobody to work there, then I mean the hospital becomes redundant. Would have to work out systems that would enable us to still give at least a satisfactory level of care, you know, without compromising health outcomes. If you go to the primary healthcare centers, for example, you have community healthcare extension workers. They are there, and they have what they call a standing order, through which, you know, they are guided to give certain, you know, level of care. Why do we have these systems? If you have to put a doctor in all of the community, you know, all of the primary healthcare centers, I mean, there are doctors there for most of them, but many times these doctors are core members and, you know, junior doctors. We know the situation with brain drain in the country and all of that. So we have to think about strategies that we can use to bring in all the stakeholders, you know, into the space and do it in a collaborative way. We're not saying that the pharmacist shouldn't know that, you know, theirs is not the first level of care. But I mean, I'm recently involved in a program also facilitated through Drugstock and my organization, whereby we are rendering, you know, services, and the first point of call is not even the hospital. We are being innovative about it. So we are making the patients go to the pharmacy and giving telemedicine, you know, services to the pharmacist, such that the pharmacist, when the patients come to the pharmacist, the pharmacist can then call a doctor through telemedicine to get the opinion of the doctor, to do the actual consultation, and whatever medication needs to be prescribed can be given to them at that point. The point I'm trying to make is collaborative work while still doing what we can to maintain the structure of healthcare so that we don't compromise healthcare outcomes. Collaborative work, you know, can be done with that mindset. That collaborative mindset can be put into it. If we put that collaborative mindset into it, we are likely going to achieve more, rather than us just having these skirmishes or fights. You know, I'm the doctor, is the lab scientist, and those sort of things. No, we understand the structure, but if we can implement those collaborative, you know, work and try to think out of the box, it would do more to the patient than us being at loggerheads with each other and fighting over supremacy. So that's my comment on your third question. Yes, family.
Thank you very much, Dr. Daniel. You took the words right out of my mouth. You know, when you started at the beginning, you said something about systematic distrust, where everybody needs to be able to trust. We need to be able to trust one another. We need to be able to trust one another to do their jobs and do it well. So thank you very much for that. Dr. Hope, do you want to add anything else, as Dr. Daniel said it all, to the question on how the immediate opportunities for reducing out-of-pocket payments?
Yes, still talking about trust, and you know, different specialties can come together. You know, starting with the family medicine, to internal medicine, to the pediatrician, to the different specialties coming together under one roof, reducing the travel time for patients, reducing the frequencies of visits and all that, and in that way it has reduced some sort of cost for the patient. You know, yes. So that kind of collaboration also works so well for patients. Yes.
Yeah, thank you very much, Dr. Hope. So it's interesting to know that even in hospitals, we still have a lot of structures that are also in silos. So even there, we need collaboration as well. So it's not external to doctors or to pharmacists. It's a system problem, and it has to be solved systematically. Like, thus we need the systematic trust. Thank you very much to our panelists. So I don't know if we have more questions in the box, but before that, let's look at the last question for all our panelists, because we are behind time. We have a lot of more questions, but maybe we can just answer. Maybe they'll help us answer it in their own time, but not on this call. So the last question will be, please let's confirm that we can still hear me.
Yes, we can.
Yes, we can hear you.
Okay, futuristic about this now. So looking ahead changes do you foresee in healthcare policies or regulations that could further support efforts to reduce out-of-pocket burdens? So what changes do we see?
Sorry, we're not sure.
All right, Famfolake, do you want to go first with this one?
Okay, right.
The question again, because I didn't, you were breaking. But I think I got the part where you said, what policies do we see, right?
Yeah, what changes do we foresee in healthcare policies? Yes. So what changes in the current policies do we see or do we foresee that will move a needle in reducing out-of-pocket payments?
Okay. Well, I think that Lagos State is probably doing something like that now, whereby they're really promoting their health insurance stuff. So what if there's a policy that says that every child or every Nigerian must have an health insurance coverage? What if there's a policy like that happens? So if that kind of thing actually happens, you know, the pharmacy has to be ready, the hospital has to be ready. For the pharmacy, you know, maybe the pharmacy has to maybe build more branches, get more branches, so that at least people can have access to enter into a pharmacy and pick up drugs or have some coverage in those areas. And another thing also, we can also leverage technology. You know, let's have more apps, more websites that we can have virtual consultations, get drugs. You understand? So yeah, that's what I feel. Thank you.
Thank you, Famfolake. I think it's just access. Basically, let's expand access to healthcare. So, for example, in a situation in an area, we should have this number of, in a local government, for example, you have this number of primary healthcare centers, this number of community pharmacies, this number based on the needs of that population. Yeah. So I think that is something that would totally work. Dr. Daniel, do you have any? Is Dr. Hope still on this call? Because I'm not seeing you.
Yes, I am.
All right. So after Dr. Daniel, Dr. Hope, you go next.
Okay.
Yeah, I mean, Famfolake has said it. Perhaps what I would just add is in response. I mean, I like the fourth question from Moses, so please permit me to just use this 1 minute to answer it. So, in reaching out to what's it called, policy stakeholders and those sort of things. First, we need to understand that we are stakeholders. A good example is how there was an increase in capitation this year from 750 to 1,200. That did not come because the policy makers, you know, just on their own thoughts that it was good and they were going to do it. It came because healthcare providers came together to advocate. So we need to start, first of all, acknowledging the power we have as healthcare providers and understanding that it is our responsibility to make, it's our collective responsibility to make policymakers do what we want, do what we feel is beneficial for us. So first of all, coming together to stop fighting each other, one. Secondly, pushing for representation asking for a seat in the table, because come on, without us, health insurance will collapse. It cannot work. They need us for it to happen. And this is what happened. I mean, these were the conversations that happened. We know that through the auspices, I believe, of HCPAN, eventually providers tried to pull out, and the policymakers were twisted into increasing, you know, that capitation. So that is the power we hold, and we need to start looking at ourselves collectively as being powerful and pushing for representation and advocating for change, you know, at that, I mean, with the policymakers. It is only then that we can have the impact that we desire. Otherwise, trust me, one organization, one hospital is going to be a needle in the haystack. However, if we can come together and, you know, pool our resources and our voices together in unison, we'll get the results that we want.
Thank you very much, Dr. Daniel. Like, we are, as as strong as our weakest link, or how is it said? So we need to really come together. You know, there's this common saying that when a bundle of broomstick is together, it's really difficult to break it, or impossible anyway. So that is the situation of things. Each of us has a power, and when we come together to collaborate, we're a lot more powerful. And you know, collaborative work is really, many of us just hear the word collaboration as something, you know, outlandish. It's when we start collaborating, we would know many issues that come up would not even see the light of day. It's just important for us to understand that we need one another to make the patient's outcome better. Thank you very much, Dr. Hope.
Yes, still speaking on this advocacy, you know, they really need to up the budget for health so that so many things can be subsidized. At the moment, it's at 3.6%, and not even up to the recommended 5%. They could still do much, much better than that. That's on the part of the government. Then on the part of healthcare providers, who said it's collaboration and more collaboration, coming together, agreeing to move forward. And then, of course, bridging the gap, like what Drugstock is doing, removing, the gap of middlemen, or especially in the supply of the drugs. When the drugs come cheaper to the patient, they pay less. And if they are more subscribed, better for them. And of course, I was going to say something and it's escaping me, but
no problem.
My thoughts. But that is it.
You can come back. Yeah.
So no, one thing. So I've talked about more budgetary allocation, and of course making this health insurance compulsory. Somebody said it, making it compulsory, and ensuring that it's taken up by individuals, both private, state, and federal. People should take up this health insurance. It helps. It goes a long way.
All right. Thank you so much. Thank you so much. Thank you very much, Moses, for your, I think your questions have really put a lot of life into this, like added a lot of life into the session. Thank you for your questions. Thank you for wanting to know more about what is going on and wanting to participate in this session. Thank you. But there's another question. Is there a central system or platform where a community pharmacy can plug to working with the various HMOs in Lagos? If no, in your opinion, what are the first 3 HMOs you would recommend for community pharmacists to work with? I think I already know the first one that Dr. Daniel will say. So I don't know if you want to answer this question live. Or maybe we'll reach out to
and I will surprise you, and I will surprise you with my response, really. Now, this is my response. First is, I do not think there is a central platform, I mean, where you can work with HMOs, except that we now have this, well, in a way, the answer is yes, because we have these aggregators, right? Pharmaceutical aggregators that sort of enlist you on their panel list, and then they can then refer enrollees. So they have several HMOs they work with. So if you are enlisted as a community pharmacy with them, you can, through them, have enrollees of various HMOs come to you to pick up medications. And the reconciliation and payment for that would happen through the aggregators. I would not mention him because we are in a branded platform. So yes, technically it exists. The second thing, the second question for me, and this obviously is a career-related question, my recommendation to you would be to work in whichever HMO you find available to work, as far as you have determined, and I'm not going to mention any name, as far as you have determined that this place is a good place to work. Meaning that don't look at the name of the HMO per se. Rather, look at the work you will do there. If you have the opportunity to do meaningful work in that HMO and you've done your findings and you know that it's a good place to work meaning that it's not toxic, a good place to work meaning that you will not be owed your salaries, then I think organization would be a good entry point for you into that
Yeah,
industry,
Dr. Dan,
because
I think he was
eventually.
talking about partnering with
Yes.
what community pharmacists
Oh,
partner with an
with
HMO.
HMOs. Oh, I see. Okay, yeah. So most of the HMOs really work through those aggregators, and I'm sure if you just go on Google, put up the name, you would have them. I suspect Drugstock might be, one of those aggregators, that do similar work as well. So if you can enlist with them, then of course you would be able to have access to a release from various other various HMOs. And the good thing is, you would have to sign only one contract rather than having to go and sign different contracts, with different HMOs.
All right, thank you very much, Dr. Daniel, for that reply. Okay, so the name is Anonymous Attendee. So I really wish you could tell us your full name and maybe drop your contact so that we can get back to you on the question and give you a more robust feedback if you want. But we're not able to know who you are because it's anonymous. Thank you so much. And thank you so much to everyone on this call. We have like a lot of questions still, but we have really overshot the time. So we're going to have to make a hard stop here.